Okay, moving over into Chapter 27, Fluid and Electrolyte Balance. Okay, first thing you need to know, intracellular versus extracellular fluids should be very self-evident. Anything that's in a cell, intracellular. Anything outside of a cell, anywhere, is extracellular. Intracellular is the dominant fluid of the body. The picture you're looking at over at the bottom right, showing you movement between cavities like serous cavities with serous fluid, lymphatic vessels and lymph moving from tissue and tissue fluid into the lymphatic vessels. The tissue is in yellow. From a blood vessel, plasma leakage out into the tissue. So again, whole lots of fluids here. Okay, some key things here. I'm not going to go into each one of these, but let me particularly mention number 2. Extracellular fluid compartment is monitored by homeostatic mechanisms. For example, when you become dehydrated, your blood plasma becomes more hypertonic than it should be. That drop in water content and rise in solute content is picked up by osmoreceptors that send information to your brain. And that causes your behavior to change, like to want to drink water. The third one, the ICF that is in the cells, is a water reservoir to cushion ECF imbalance. When you become dehydrated, and that ECF would become more hypertonic, there will be a shift of fluid from inside the cells out into the ECF, like the blood, so that the two solutions stay pretty much isotonic to each other. Just like waters move from Lake Lavon or Lake Bray Hubbard into the water supply system of the city of Dallas to keep the pressure enough for water to get through your pipes into your house. Water transport, only osmosis. Pressures, osmotic and hydrostatic pressures, are moving things. You know that very well by now, should. You look on further down, you see that electrolyte fluctuations affect water balance, and vice versa. You screw up electrolytes, you mess up the water. You mess up the water, you become dehydrated, for example, that screws up electrolyte concentrations. Okay. Reminder. Let me show you what's underneath here. I know you may not have ever thought you're going to see it again, but boy, are you going to see it again. You need to know this. You may need to go back to general biology. You are going to see this in nursing and in medicine and in PA. You may not like it, but you better get used to these terms and what happens to a cell that is in a hypertonic solution, hypo, whatever. Okay, so what you're looking at right here is a reminder. Okay, so look right here in the middle at the situation, which is the norm, isotonic. So across a cell membrane, any membrane, the two solutions, solution in the cell, solution on the outside of the cell, are the same. And I don't mean the same, I mean the same tonicity, the same osmotic pressure. I didn't say they had to be the same solute. Now the representative solution that you always use when you're talking about what the tonicity of it is inside of a cell is generally an NaCl solution, and usually it's 0.9%. If you want to be even more factual, it should be 0.85%, but usually it's just rounded up. So if you have any kind of cells sitting in a tube with 0.9% NaCl, the two solutions in and out of the cell are comparable to each other in solute, in osmotic pressure and solutes, isotonic. There will be no net osmosis. In other words, the cells will be normal. There will be molecular motion going in and out of the cells and water going in and out of the cells, but there is no movement more in than out. Everything is stable. The other isotonic solution to a cell is 5% glucose. 0.9% NaCl is also isotonic to 5% glucose. If you look at IV bags in a hospital, they will say on them 0.9% NaCl, 5% glucose. Get used to it. Okay, so look at the hypotonic solution to the left now. If you put your cells into anything less than a 0.9% NaCl solution in your tube, or anything less than a 5% glucose solution, or you put them in distilled water, which obviously has neither glucose nor HCl, the solution outside is hypotonic, less solute, than what is inside the cell. Water always osmoses from hypotonic towards the solute, which is in higher concentration, towards the hypertonic solution. The water moves in, cell swells, bursts. You did that in general biology. Okay, if you go over to the hypertonic solution, now you put the cells in a high solute solution. It could be anything over 0.9% NaCl, like a 1%, a 2%, a 5% NaCl solution, whatever. Or anything over 5% glucose, 10% glucose, 20% glucose, doesn't matter. If it's higher solute on the outside than on the inside of the cell, that solution is hypertonic. The cell now is hypotonic to the outside. Water moves out, cell shrivels. Remember that. You cannot get away from tonicity and these terms. Okay, so water balance. This is the easiest part of the chapter, actually. Water in is equal to the water out. If you're not taking in as much as you are dumping out through sweat, through urine, you have an imbalance. If you are bringing in more water than you are eliminating, you're not peeing it out, you're not sweating it out, you have a problem. You've got to remember, intake equals output. On the left, you see green arrows listing different ways you get water in the body. Some of them you just like throw in your body, like drink. But notice metabolism. You make water in the body. It's a byproduct of cell metabolism. It's not a huge amount. It's just a little bit. Okay, in yellow arrows, you see excretion of different types, the ways water's lost. I don't think there's anything for us to go into here. Okay, another example up at the top right. Ways it comes in or is in the body, ways it gets out. You see a negative feedback mechanism at the bottom showing control of water balance in the body. So the point here, we start out with a situation over here. Either you're not drinking enough fluid, that's this situation here. I don't know, maybe you're exercising or whatever. Or combined with the fact you're not drinking enough fluid. Or look at this down here. Let's say you've eaten 1.5 gallons of salted popcorn. Alright? Increase osmolarity or osmolality of the extracellular fluid. Either gets you to the same place. Alright. Remember I said that you have osmoreceptors monitoring osmotic pressure in the blood. Okay, so here we go. They send information to the hypothalamus. You got a thirst center in there. You get the desire to drink. Notice also less saliva, dry mouth. That also makes you want to drink. You get more fluid intake in the body. That increases your fluid, extracellular fluids, more water in, and it decreases the osmolality of the extracellular fluid, so it's not as salty from your popcorn, and we're back to balance. That's a negative feedback mechanism. Regulation, also notice ADH. ADH is for you to retain water. It's made when you become dehydrated, or when you lose fluid in the body, or when your blood pressure drops. It's made by the pituitary. It tells your kidney tubules, the DCT and the collecting ducts, to become more permeable to water. Water follows the salt. Remember, countercurrent multiply process. You retain the water in the body. Okay, here's exactly what I just went through on the ADH. Okay, problems here. Diabetes insipidus, not making enough ADH. ADH allows you to retain water, keep it in the body. If you don't make ADH or enough ADH, instead of keeping it, you're peeing it out. It can be very severe. It can cause death. We're not talking about urinating a lot. We're talking about 10 to 15 liters a day. So right away you should be thinking severe dehydration. And you can see then how that would affect electrolyte levels. Because when you become severely dehydrated, think about what happens to your blood sodium and your blood calcium and blah, blah, blah. Okay, so dehydration. You can have dehydration without diabetes insipidus. You can, again, just be out playing tennis in the summer without drinking enough. Okay, now, the flip side of diabetes insipidus and dehydration, water intoxication, or sometimes called overhydration. So look at the picture on the right. I can't get rid of these marks. I don't know why. My marks won't go away. Guess I'll just erase them that way. Okay, so anyway, you're drinking too much fluid, all right? Here's your, wait a minute, let me get, I think I'll change it to red. Okay, so too much fluid coming in, or your kidneys are not getting rid of it. Either. You got too much fluid accumulation. All right, so here we are. Too much water in the ECF. Now remember, ECF here, ICF here. You see the cell right over here on the right. You've got too much water in the ECF. This is now going to become hypotonic to the ICF. Remember, before this disorder, they were isotonic to each other. But now that the ECF has less solute and has become hypotonic, then the ICF obviously has to be hypertonic. You can't have hypo on one side and iso on the other. If one's hypo, the other's hyper. Now, water moves from hypotonic towards hypertonic. That's exactly what you see happening right there. The cell swells as the water fluid goes in. Now, let me erase some of this. Okay, so what's going to happen as the water moves into the ICF is that at some point, these two things are not one being hyper and one being hypo. At some point, these guys are now going to become the same solution again. Isotonic, isotonic. Except everything is askew now, because remember that you have too much fluid in the body. It's just the fluid shifted over into the cells. So we're not back to square one yet. It's just better than the situation where the cells swell and explode. You obviously don't want that to happen. Now, again, in the case of dehydration, the reverse happens. In that case, your ECF, you're losing fluid, goes up in osmotic pressure. So now, again, it becomes hypertonic. And here is your cell, ICF, and it's now hypotonic. And in order to try to get these back into balance, there's a shift of fluid from the cells, ICF, back into the ECF. Remember, ICF is the water reservoir for shifting back and forth into ECF to keep it balanced. When these guys now get balanced, we're back to, or at least as much as we can, iso and iso. But again, we're not really quite yet in balance. It's just we're more in balance than one being hypo and one being hyper. And eventually you drink more water, and when you drink more water, then that fluid shifts back into the cells and everything is righted again. Okay, so in edema, which is obviously fluid accumulation, that fluid stays in interstitial compartments. And again, remember, interstitial is ECF. And you get these symptoms that you see right there. And I can tell you from having 2 sprained ankles, and you possibly also having a sprained ankle or a broken whatever somewhere along the way, you've had edema, swelling to the extent that your foot can't go in a shoe, pitting edema, which means there's so much fluid accumulation. If you push down with your finger, a pit develops where the fluid has been pushed out of the area. And then you take your finger off and eventually the pit fills with fluid again. Increase in body weight because you're accumulating fluid. Functional impairment. Boy, is it tough to walk around on a sprained ankle or do anything with a broken arm that hurts like hell. And pain, and also as well as arterial circulation problems, because that fluid accumulation causes pressure in the interstitial spaces, and that puts pressure on capillary beds, and it impairs circulation. Okay. Causes. Increased blood hydrostatic pressure. Look at the right-hand side. Look at the arrows going out. Too much hydrostatic pressure forces plasma out. Hypertension, for example. Loss of plasma proteins. Oops, didn't mean to do that. Okay, look at the bottom right. Your liver, for example, not making enough plasma proteins, or maybe too many plasma proteins lost in urine, whichever. So now, remember, osmotic pressure in blood keeps fluid, pulls plasma, pulls water in to keep it in the blood. You don't have that force. The dominant force is hydrostatic pressure pushing outward. You get more leakage of plasma out into the tissue. Obstruction of the lymphatic circulation. Look at the left. The fluid can't be removed in the lymphatic tissues. It backs up. It sits in the interstitial spaces. It can't go, it doesn't necessarily go back into the blood, but it can't go forward into the lymphatic vessels, and it sits there. And then last you have increased capillary permeability. You see right over here where the capillaries, due to inflammation, other things, heat for example, they become leakier, and the dominant pressure again is hydrostatic pressure pushing outward, and you get too much fluid out there. Okay. Let me go through electrolyte balance. Yeah. Okay. So you know some of this already from water. Intake, output, they got to equal. There's not much else to say. Over here on this picture, let me get rid of the bar. All right. So cations, they're positively charged, like sodium, calcium. Anions, negatively charged, like chlorine. Don't sit down and memorize those. Notice bicarbonate is over there in the anion group. All right, so Notice the things that are highest in plasma. Plasma, sodium, plasma, chloride. Remember, it wants to follow sodium, NaCl. Those are the dominant things that you find in blood. All right, let's go into the cells. Could be liver cell, kidney cell, muscle cell, whatever the hell you want. Okay, here's potassium for the positive charged guys. Here's phosphate. Here's proteins. We'll talk more about those. And you got some other odd and end things. Also, proteins are over here in plasma, too. There. All right. Interstitial fluid is pretty much like blood plasma. Look at that. Real similar. And over here for the anions, it's real similar. Differences, fewer proteins. Okay, the hormones. Take a look at them. We've been through all of those. Think about what ion is affected by each one of these. Does it go up? Does it go down? I'll give you one to start with. Aldosterone comes from the adrenal cortex. You make more aldosterone to conserve sodium, but at the same time, instead of potassium being conserved, it's being excreted. So aldosterone causes sodium retention. It causes potassium loss. Go through each one of these hormones. We've been through every single one of them. And think about what electrolyte it affects. Does it increase or decrease it when it goes up or down? Okay, the three main ones, electrolytes that we're going to talk about. Sodium, potassium, calcium. You'll cover way more of this in a pathophys course or in fluid and electrolytes when you cover them in a nursing course. Remember, this is absolutely tied to water balance, particularly sodium, because it's the most common of all of the electrolytes in the body. So, again, this picture is just showing you everything we just talked about. You got a cell. Here's the cell in green. The solutes are in blue. The inside of the cell is hypertonic. The outside of the cell is hypotonic. Water moves from hypo to hypertonic. Cell swells. Bottom, the opposite effect. The outside, ECF, hypertonic. Inside, hypotonic. Fluid moves out. Water moves out osmotically. Cell shrinks. Okay, so looking at these three. Sodium, the most common of the solutes. Too much, hypernatremia. Too little, hyponatremia. Think about what causes this. Fluid loss, when you become dehydrated. If you're sweating a lot, you're not taking fluid in, you're out playing tennis in the sun, you're going to perspire and lose a huge amount of fluid, but you're going to lose less electrolytes. I know there are electrolytes in perspiration, but perspiration is mainly water. So what you have then is more solutes left in the ECF. That means you're going to have high sodium in blood. You will also have high calcium in blood, high potassium blood, high any electrolyte in blood, because you're losing water. Diabetes insipidus. Again, remember that's just severe dehydration. Burns. What do you lose when you're severely burned? Plasma. That's what pops out when those, goes out when the blisters all break. Too little salt. That's not all that common, but if you were to overhydrate, drink way too much water, all of your blood electrolyte levels go down. The sodium, the potassium, everything. Okay, jump down to calcium here. Hypercalcemia, too much calcium. It could be overloading on calcium by pill. It could be PTH. Remember parathormone? It shifts calcium from bone into blood. You have too much of that, that's exactly what's going to happen. Hypercalcemia. That's why pregnant women tend to get hypercalcemia and kidney stones, because they have an increase in PTH, because you got to free up the calcium of the woman from her bone to make it available in the blood for the fetus. Sorry, the fetus is like a little parasite, calcium speaking anyway. Okay. What happens if you have high and low sodium and calcium levels? Remember, these guys are really involved in nerve impulse transmission, muscle contraction. So obviously that's going to affect those. The calcium particularly has a dramatic effect when high or low on the heart. Too much, you go into spastic contraction of the heart. Too little, it becomes less, there's less strength of stroke volume, the contraction of the heart. Potassium. I've got this in red for a reason, and that's because when it swings out of balance, you're dead. This is the one that is going to kill you when it's too high and when it's too low. So, hyperkalemia, K for potassium, again. Also really important in heart, excitability of the heart, as well as muscles, muscle contraction, muscle spasms, spastic contraction of the heart. Hypokalemia, arrhythmias, non-responsiveness of muscle, blah, blah, blah. How do you get it? Well, I've already talked about some of them, but let's talk about other things. Think about aldosterone. If you've got Cushing's disease, you got too much aldosterone, right? As well as cortisone. Now, if you've got too much aldosterone, your blood sodium is going to go up because you retain sodium. But what's going to happen to your potassium? It's going to go low because potassium's getting dumped out of the body. So, in Cushing's disease, you can have hypernatremia, but you have hypokalemia. You got to think about it. The symptoms of these problems are very similar to what you get when you're dehydrated or over hydration, in addition to some peculiar symptoms. In your notes, you'll notice I gave you some examples, more detailed examples of what causes these. Okay, I'm stopping here. The last unit is acid-base balance.